and welcome to today's lesson on rapid sequence intubation. Rapid sequence intubation, or RSI, is a staple in the ED. You're going to see this almost every day in every trauma center in the country. It's a complicated process that's really broken down into very specific steps. And if you know what's happening and what comes next, you can properly assist the doc with the procedure and really make the process much easier. So RSI is a cornerstone of emergency management. It's a skill that every ED doc has and uses. As nurses, we got to know some very specific things. What are the indications? Who needs to be in the room? And with those people that are in the room, who actually helps with the procedure? We need to know what we need, like equipment and meds, that kind of stuff. And then what do we need once the tube is in place? And of course, what is our role as the nurse? First thing we need to know is when to use this. Well, just like any intubation, it's used for protecting an airway. And whether you do it fast or slow, protecting the airway is the end result. We also see it for respiratory failure. Like if a patient's respirations are slowing or getting to the point where they're no longer breathing on their own, we're going to step in with RSI. There are those who are going into shock. They also can't protect their airway. Patients with intracranial hypertension, also, they can't protect their airway as they start to deteriorate. And as well, the insertion of that ET tube can actually help to reduce some of the pressure by reducing their work of breathing. We also want to make it easier for patients who may have like severe acute respiratory distress, like our asthmatics and our COPDers. As with any procedure in the ED, you need people, right? Not too many, mind you, but enough to get the job done. You're going to need an ED doc, and that really can be the attending, resident, fellow. It really doesn't matter. You just need a doc there. In many of the facilities I've worked in, the doc is actually the one passing the tube. You're also going to need some nurses. One is good, two is better. One's usually assisting the doc directly, and then the other one can draw up all the meds. You probably want a respiratory tech. At the very least, they're there to kind of set up the vent. But in some facilities, the respiratory tech is actually the one who passes the tube. And of course, it never hurts to have some PCAs along with you. They can be there to gather equipment, get vitals, do other simple tasks. I use the term PCA, or patient care associate, but they have many names. Basically, it's the nurse's aides. So in order to do this, we need some equipment. Now, once we've ventilated the patient with the bag valve mask or the BVM, and we've gotten their oxygen level up, we need a laryngoscope to open the airway and to help visualize the cords. Now, sometimes the doc will use something called a glidoscope, which is this fancy thing right here. It's basically just a laryngoscope attached to a monitor. There's a little cord on the end of it. And what it is it allows the doc to visualize the cords on the monitor. Some people like it, some don't. It's personal preference. You obviously need the ET tube, the endotracheal tube. Now, please, when you are getting this, make sure the stylet, which is that rigid, bendable kind of stick tube that slides inside the ET tube, make sure that's in place. Without it, the ET tube itself can almost become too flexible to actually insert down the airway. So the stylet adds some rigidity to the tube and makes it easier to pass. You're also going to have that colorimetric capnometer. I know it's a very fancy term, but that's that little device that you attach to the end of the endotracheal tube that changes color from purple to yellow to indicate the presence of carbon dioxide, and it's a verification tool. Once you have all your equipment ready, you want to make sure you have the right meds. Now, some protocols call for sedation prior to induction. Meds like midazolam or fentanyl. Those are very common for sedation. Once sedation's on board, or as a starting point, you want to provide an anesthetic, basically to knock the patient out. One I'm most used to using is etomidate. But you can also use ketamine or propofol, something like that. And then once the patient is, quote unquote, down, you want to paralyze them so that now you can pass the ET tube. My favorite here is succinylcholine, or SUX. Whoops, SUX. And then other common meds here are rocuronium and vecuronium, or ROC and VEC. You don't want to use all of these at once. You kind of pick and choose the ones from each category: the sedative, the anesthetic, and the paralytic. Now, once that tube is in place, there are a couple things we need to do. So we want to make sure the patient remains sedated and doesn't fight the tube. You can see them, they'll bite down on it. They might try to pull it. The common infusion here is good old propofol. But there are some other meds you can use like lorazepam or Ativan. We also need some extra equipment here. So you want to get a tube securing device. Now, it's basically to hold the tube in place. So this can be something as simple as tape, which wraps around the patient's head and around the tube and secures that in place. There are also actual ET tube holders, which have a little clamp on them that sits over the mouth and holds the tube in place. You also want to make sure that you have a working ventilator. That's where the respiratory techs come in. You want that at the bedside so you can attach the ET tube right to it. Frankly, begging can get tiring after a while, guys. Depending on the patient's level of sedation, you might want to consider wrist restraints here. Restraints. And that's just basically to prevent them from reaching up and pulling the tube out. Now, of course, please check with your facility's protocols on this one. So the big question is, what do we do here? Right? What's the nurse's role? Well, when we decide to tube a patient, when the decision is made, we need to get those meds, right? The process can't really go anywhere if the patient is awake and alert. You don't believe me? Give it a shot. See what happens. But don't do that. In terms of what we can push, what the nurses can push, most states allow nurses to push meds like etomidate and Sux, but they frown on pushing something like propofol. You guys all really need to check with your state and your facility on what you can push and what you can't, because it can change from state to state. As the doc's getting all the equipment ready, we can be ventilating the patient with the BVM, the bag valve mask. And as he visualizes the cords with the laryngoscope, be there to hand that ET tube to pass to him, to have that in hand. Once they visualize the cords and they're looking down the airway, they don't like to look away. So a lot of docs or techs just reach out a hand, like a blind hand, for you to place the tube into. So do that. Once the tube's in, we need to verify placement. So we're going to attach that capnometer. We're going to listen for breath sounds and also make sure that you put in for that chest x-ray, which is really confirmation. During the entire process, we're nurses. Keep an eye on the vitals, especially that O2 sat. As they work to kind of visualize the cords and you're not bagging them and the patient's not getting O2, you're actually going to see that O2 sat drop. So let the doc know when it's getting low. Like if it starts hitting below 90%, raise your voice. Let them know. They might actually have to stop and ventilate the patient to bring the sat back up again before they try to pass the tube. And then once everything's in place and confirmed, we need to monitor the patient and titrate that sedation as necessary. So guys, it's no secret that we perform RSI to maintain good oxygenation. Make sure we're watching the O2 level. You got to know your meds. It could be really bad if we hand the doc the wrong thing and wind up paralyzing the patient before sedating them. And with any good ED test, we know prioritization is always key. Yes, we want to get them intubated, but we also want to make sure we have a good O2 sat before we do that. A few key points. We want to know why we're intubating and, how we're going to do it, like the how and why. Make sure you have all your equipment before you start the process. It's really not a good thing if you go to intubate somebody and you don't actually have the ET tube. Know your meds and please try not to mix them up. We have to monitor throughout the process, and this continues after they're intubated, and along with keeping an eye on their sedation level. You don't want them to wake up and pull the tube out themselves. Trust me, I've seen it happen. So thank you guys for joining us on this quick overview of RSI. Please check out all our other emergency medicine lessons here on nrsng.com. And as always, happy nursing.